Similarly, bladder biopsy as a part of initial workup is supported by only few organizations like ESSIC and the European Association of Urology. Well, the rest of the organizations throughout the world, they take it to be either optional or they don't recommend it. So why we need a cystoscopy in bladder pain syndrome? We know that cystoscopy has a both diagnostic and a therapeutic value. So if we do a cystoscopy with hydrodistension, we can document the stigmata of bladder pain syndrome like glomerulations and Hunner lesions. In the meantime, we can rule out many disease conditions which can present as a bladder pain syndrome like carcinoma in situ, tuberculosis, eosinophilic cystitis, and etc. So we can take a biopsy, we can assess the bladder capacity, which probably will guide to us whether the patients will be benefited by doing a therapeutic hydrodistension or not, although it has got its own limited efficacy. So since the patients will be taking under general or regional anesthesia, it can be an opportunity to ablate the Hunner lesion by means of different energy sources. And after all, considering all the findings, gross findings in the cystoscopy and the biopsy, we can make an overall prognostic, prognosticate the disease in future. So there are certain rules to have a cystoscopy. And we know that the hydrodistension is an essential part of a diagnostic evaluation if you do a cystoscopy. So normally the rigid cystoscopy is preferred over the flexible cystoscopy because of its better optics, ease in taking multiple biopsies, and a good better channel for the irrigation. The patient has to be taken under some form of anesthesia, either a general anesthesia or a regional anesthesia. Local anesthesia is rarely condemned because the patient is already having a pain. And on top of that, if we are distending the bladder, it will be unbearable. So we do not recommend a local anesthesia. The irrigation height has to be maintained at around 80 centimeters from the symphysis pubis. And we have to see the bladder when it is not fully distended, like we do in a regular cystoscopy, when the volume is around 150 to 200 ml for the pre-existing lesions, and especially for the Hunner lesion, because once we distend the bladder, the Hunner lesion might disappear. And we continue to fill the bladder till the irrigation stops on its own. But we should not exceed the volume by 800 ml or 1 liter, even if it continue to go also. And there are two options. If we are taking the patient only for a diagnostic hydrodistension, the duration of distension should be of around 2 to 3 minutes. But if we are taking the patient for a therapeutic hydrodistension, the duration will be up to 8 to 10 minutes. After it's completely distended, we empty the bladder and note the effluent and collect the amount also, measure the amount, and the amount which is measured gives the maximum capacity of the bladder. And if there is a hematuria, especially in the terminal part of the effluent, that indicates that there are lesions which has bled. And normally the bleeding stops by putting a irrigation catheter overnight. Subsequent distension is not done with the maximum capacity for a better visualization of the lesions. There should be also.
Hello.
Hello.
Hello. Can somebody please unmute their mic? Somebody who's not a speaker, please unmute. Please mute your mic.
Yes. The lesions, yes, the lesions should be described in a systematic way, and the biopsy should be taken once the hydrodistension is over. We should not take the biopsy in a fully distended bladder or before going for a hydrodistension, because it can lead to a perforation of the bladder. And we need to take at least 3 biopsies from different areas in addition to the biopsy from the lesions. This is how I have picked up from a journal of urology. This is how the documentation has to be made with the diagrams. Now I would like to talk something about the specific lesions like Hunner lesion and glomerulations, which we pick up during cystoscopy. The Hunner lesion prevalence is 5 to 57%. It's a widely variable because the most important problem in not picking the Hunner lesion is due to the lack of experience of the person who does a cystoscopy. And the Hunner lesion has got a distinct clinical, pathological, and treatment differences. Like the previous speaker, Dr. Manish also has highlighted that now the trend is towards gradually going towards differentiating a patient from with the Hunner lesion versus non-Hunner lesion. So Hunner lesions, we have to pick up the Hunner lesions in the not in the fully distended bladder initially, because once it gets fully distended, it might be obscure. These are the few pictures showing the Hunner lesions. Like in A and B, we can see the Hunner lesion. What is the C picture? In the C, we can see post hydrodistension edematous mucosa, and D is showing the waterfall pattern of the bleeding. Now, glomerulations is given so much of emphasis in NIDDK criteria, but glomerulations are not so specific to the bladder pain syndrome, because it can simply be a reflection of the rupture of the vessels in a previously underfilled bladder. And it can be detected in various conditions like neoplasia, different forms of cystitis, infective radiation or chemical cystitis, and chronic underfilled bladder. These are the few pictures showing the glomerulations and the typical rainfall pattern of bleeding. Remember that if the Hunner lesions, it gets stressed during hydrodistension, it gives rise to a waterfall pattern of bleeding, means the bleeding is more profuse. But if there is a bleeding from the glomerulations, then it gives rise to a rainfall. That means the sparse. It's not so profuse bleeding. Now, ESSIC has given a cystoscopic classification from grade 0 to grade 5, indicating the severity of the disease. Now, after going through the cystoscopy with hydrodistension and biopsy, again, the ESSIC has given a subtyping of the bladder pain syndrome. So it indicates, like, if it is a 3C, that means there is a Hunner lesion in the cystoscopy, and C represents the severely inflamed nature in biopsy. So it is indicated by the two things. Number represents the cystoscopic finding, whereas the later alphabet represents the biopsy finding. Something about a cystoscopy in therapeutic hydrodistension. It has got a short-term efficacy up to 60%, whereas the efficacy almost becomes zero by the end of 6 months to 1 year. And it is found to be more effective in patients with Hunner lesion in small capacity bladder. The possible mechanism of action are basically the degeneration of the efferent nerve endings due to a pressure of the distended bladder. So there are again not the different levels of recommendations, and the overall level of evidence for therapeutic hydrodistension is 3 and recommendation is grade C. Now, something about narrowband imaging cystoscopy, as we know that in other conditions also, like especially in malignancy also, the chances of picking up the pathology by narrowband imaging is far superior as compared to the white light cystoscopy. And so if we use a narrowband cystoscopy, it may avoid the hydrodistension, and we can pick up the lesion in the early phase. These various pictures showing the narrowband imaging images, you can see that. So it can be a better armamentarium as compared to the white light cystoscopy. Finally, there are certain limitations of the cystoscopy, as you know that it is contraindicated in UTI, pregnancy, past history of perforation of the bladder with hydrodistension, and if the patient is of high anesthetic risk. There are certain complications like hematuria, clot retention, urosepsis, bladder rupture, and bladder necrosis, which is a very rare entity. So to come to a conclusion, although cystoscopy is not widely recommended as an initial diagnostic tool, but anyway, it can provide us an objective evidence for the diagnosis, classification, management, and prognosis of bladder pain syndrome. The standardized diagnostic criteria gives a uniformity and comparability of the studies, which can be documented through cystoscopy. And it can, in the meantime, it can rule out the dreadful conditions which might present as a bladder pain syndrome, and which might be treating for a long duration before finally it goes into an advanced stage. With this, I would like to conclude my presentation, and I would like to thank NAUS and GIBS for this opportunity. Thank you.
Thank you, Dr. Ghanshyam, for the extensive elaboration of the cystoscopic finding. During your presentations, I found some comments from Dr. Siva Priyadarshi. So I'll request sir to take this forum for a few minutes and highlight about the Hunner ulcers, because this is considered as one of the hallmark for the disease, diagnostic criteria for this disease. So requesting Dr. Siva Priyadarshi to take few minutes highlighting on this topic.
A very good evening to all of you. I compliment and congratulate Dr. Pawan and his team for taking this initiative. And I'm really feel happy that we are working together, both India and Nepal, both societies. As you said, Dr. Ghanshyam was saying about the Hunner's lesion. Cystoscopy is one of the most importantly used just to differentiate between a Hunner's IC and a non-Hunner's IC. And as he said that it should be seen only in a non-distended bladder, and after distension it disappears, which is probably not true. What we see usually is a scar which has a radiating vessels around, that is a Hunner's lesion. And when it gets, the bladder gets distended, there may be a crack or ulceration in that lesion with subsequent bleeding also sometimes. So it won't disappear, but the lesion would crack or ulcerate. Secondly, as I said about the, as I said, sometimes you may not see the stigmata on a non-distended bladder. So a diagnostic hydrodistension is also required in these cases, as he has also mentioned in his talk, to produce these stigmata. So not necessarily that you have to see all these stigmata in a non-distended bladder only, without distension. And the third thing was about the therapeutic hydrodistension. 8 to 10 minutes hydrodistension, most of us would agree now that is not required and may be counterproductive or may be dangerous also in some of these patients. So maximum 3 to 5 minutes hydrodistension is quite enough to produce the result. So that was my take on Hunner's lesion and all. Yeah. Thank you.